Good afternoon. My name is Erwin Chemerinsky, and I'm the Dean of Berkeley Law. There are many things that the law school will be doing this summer and the next academic year to focus on issues of race, racism, and American law. One of them is a series of programs focusing on issues with regard to race in the law. A couple of weeks ago, we did a program with regard to race and policing. Today's program is going to focus on race, law, and public health. We have four terrific speakers to address this topic. I'm going to introduce each of them to you. I'll introduce them all at once, and so that you just be listening to them over the course of the next hour. And I apologize in advance to them that I'm going to do very short introductions. I want you to have the time to listen to them and not to hear me. So let me just tell you a little about each of them, and they'll speak in this order. Khiara Bridges will speak first. She's a professor of law here at Berkeley Law. She's a graduate of Spelman College. She has a JD and a PhD in anthropology from Columbia University. She taught for many years at Boston University. She's the author of books and many articles that deal with the topic we're focusing on today, race, health, and American law. She joined the Berkeley Law faculty in 2019. Next, we'll hear from Mahasin Mujahid. She's Chancellor's Professor of Public Health and an Associate Professor of Public Health. She's Director of the Epidemiology, Biostatistics, MPH program. She received a bachelor's from Xavier, a master's and a PhD from Michigan. She was also a fellow in the Robert Wood Johnson Health and Social Science program at Harvard University. The third speaker will be Osagie Obasogie. He's the Haas Distinguished Chair and Professor of Bioethics and Joint Medical Program in the School of Public Health. Received an undergraduate degree from Yale, a JD from Columbia, and a PhD from the Berkeley Program in Jurisprudence and Social Policy. And the last speaker this afternoon will be Tina Sachs. She's an assistant professor in the Berkeley School of Social Welfare. Just last year in 2019, Oxford University Press published her book, Invisible Visits, Black Middle-Class Women in the American Healthcare System. Before becoming an academic, she spent 10 years at the Center for Disease Control and also in many positions with regard to public health. I think you can see we have four terrific speakers to address this enormously important topic, but public health, the law, and race. And with that, I'll turn it over to my colleague, Khiara.
Thank you so much for that introduction, Erwin, and thank you for providing us the opportunity to share our research and our insights on race, law, and public health. So I'm just going to share my screen quickly. And begin. Most are aware that there are dramatic racial disparities in health in this country. Researchers have long documented that Black people have higher rates of every major common illness, including heart disease, hypertension, diabetes, lung disease, and asthma. I should also mention, because of my research, that there are racial disparities in maternal and infant mortality. Black babies are twice as likely as white babies to die before their first birthdays, and Black women are 3 to 4 times as likely than white women to die during pregnancy, childbirth, or shortly thereafter. Today, I want to focus on one extremely popular explanation of why people of color are sicker and die earlier than their white counterparts. This is the implicit bias explanation. There are significant limitations to the widespread tendency to explain racial disparities in health and racial inequality generally in terms of implicit bias. And so I will spend my time today first describing the literature on implicit bias, and then I'll discuss the dangers of explaining racial disparities in health in terms of its implicit bias. So in 2005, the Institute of Medicine, or the IOM, which is now the Health and Medicine Division, or the HMD. The IOM released a report documenting that people of color receive lower quality healthcare than white people, even when one controls for insurance status, income, age, and severity of conditions. And by lower quality healthcare, the IOM did not mean that physicians were not smiling at their Black patients as frequently as they smiled at their white patients. The IOM did not mean that physicians made eye contact with their Black patients less frequently than they made eye contact with their white patients. No, when the IOM said that people of color were receiving lower quality healthcare, it meant that people of color were not receiving the same treatments that their white counterparts received. The IOM reported that racial minorities are less likely than white people to be given appropriate cardiac care, to receive kidney dialysis or transplants, and to receive the best treatments for stroke, cancer, or AIDS. And the IOM concluded its report by describing what it said was an uncomfortable reality. The report said some people in the US are more likely to die from cancer, heart disease, and diabetes simply because of their race or ethnicity, not just because they lack access to healthcare. And many studies since the IOM published this report have buttressed this finding in the IOM's conclusion. Most researchers have explained this phenomenon that was identified by the IOM in terms of implicit biases. The idea is that providers have negative views about racial minorities of which they are not consciously aware, and these views lead them to make unintentional and ultimately harmful judgments about the care that they give people of color. Many of you are familiar with the implicit association test, or the IAT, and this is a test that purports to measure test takers' implicit biases by asking them to link images of Black and white faces with pleasant and unpleasant words under intense time constraints. Now, when physicians are given the IAT, they tend to associate white faces and pleasant words more easily than Black faces and pleasant words. In fact, research shows that these anti-Black or pro-white implicit biases are as prevalent among providers as they are among the general population. Essentially, there's nothing about med school that automatically cleanses you of the biases that you had before entering. Further, there is research that purports to show that providers' implicit biases impact the healthcare that they give. For example, one study showed that physicians whose IAT revealed them to harbor pro-white implicit biases were more likely to prescribe pain medication to white patients than to Black patients. Another study administered the IAT to physicians and then asked them whether they would prescribe thrombolysis, which is an aggressive yet effective treatment for coronary artery disease, to patients presenting with a range of symptoms for the disease. The experiment revealed that physicians whom the IAT test revealed to harbor anti-Black or pro-white implicit biases were less likely to prescribe thrombolysis to Black patients and more likely to prescribe that same treatment to white patients. So if these studies are up to something, then implicit biases might be contributing to racial disparities in health. When a lot of people and institutions ranging from the media to medical schools and residency programs, when these institutions discuss racial disparities in health, this is the focus that they tend to have. The focus is on implicit bias. And with regard to medical education specifically, when programs address racial disparities in health, they either explain it entirely in terms of race-specific genetic variations, which is so problematic that I don't have time to get into it today. I will just say that race-specific genetic variations are a figment of our collective imaginations. They are a lie disguised as the truth. Or when medical schools address racial disparities in health, they talk about implicit biases. And the woke medical schools may even give students an IAT so that students know that they have implicit biases and the extent of them. And then programs tell students and residents to go out there and be mindful about how their documented implicit biases may influence the healthcare that they give. And that might be laudable. But the issue is that racial disparities in health cannot be explained entirely in terms of implicit bias. That is, the fact that providers have implicit biases is an incomplete explanation of racial disparities in health. Implicit bias has to be put in conversation with institutional and structural racism. And so in the balance of my remarks, I will discuss the analytical limitations of the field of implicit bias. And then I will ask the question, what would we see if we put implicit biases in conversation with systemic racism? First, the field of implicit bias is limited on its own terms. The field is focused on the individual and the prejudices and aversions that he may or may not possess. And note how this focus is a piece with traditional understandings of racism, understandings that posit that racism is what happens when racist individuals think racist thoughts and then do racist things. Progressive theorists of race and racial inequality have fought tooth and nail against this very narrow formulation of racism. We posit that in the post-civil rights era, racism is better defined as what happened when institutions and structures operate in race-neutral manners, but that nevertheless perpetuates historical racial disadvantage and produces new forms of racial disenfranchisement. Nevertheless, implicit bias remains squarely in that individual-centered paradigm. And this framework causes us to think of racism as a private concern, which in turn mitigates any responsibility that the state and society more generally has for the eradication of racism and racial inequality. So we might be skeptical of implicit bias research because it might commit the error that non-critical thinkers of race make. It focuses on individualist racism and ignores institutional and structural racism. We might be focused on providers' implicit biases while ignoring the two-tiered healthcare system within which providers operate. We might be focused on figuring out whether providers can match a white face to a positive word faster than they can match a black face to that same word while ignoring social determinants of health. Further, there is a compelling argument to be made that the problem is not that individuals have implicit biases. Instead, the problem is that we have constructed a society wherein people of color are at the bottom of most measures of social well-being. People of color more frequently bear the burdens of poverty than white people. People of color are incarcerated more than white people. People of color are confined in immigrant detention centers more often than white people. People of color rely on the social safety net more than white people. People of color are unemployed more frequently than white people. People of color die violent deaths more often than white people. And it is doubtful that implicit biases alone can explain these disturbing inequalities. More likely, the reverse is true. These inequalities explain implicit biases. And so it is for this reason that progressive race scholars have argued that the best approach to dealing with implicit biases is through a sustained process of social change that results in the elimination of racial inequality. If people of color are not invariably located at the bottom of social hierarchies, providers likely would not have negative implicit biases about them. But perhaps most importantly, the field of implicit bias needs to be put into conversation with structural racism. And what would we see if we actually paid attention to institutional racism? We would see that individuals with implicit biases, as well as individuals without implicit biases, are all practicing medicine within a two-tiered healthcare system. This is a system that allows for the privately insured to access healthcare that is simply better than the publicly insured, not to mention the uninsured. And to make this point as tangibly as possible, I'm just going to give a shout out to my first book, Reproducing Race. This is an ethnography of an obstetrics clinic in a public hospital in Manhattan. I call the hospital Alpha. And the thing is that Alpha is a good hospital. It is world-renowned for research and innovations. However, those achievements do not exempt Alpha from its status as a public hospital, which means that Alpha must depend on government dollars, which are always in short supply. And the result is that Alpha is plagued by problems that visit many public institutions. It is underfunded, it is understaffed, and moreover, the equipment that the staff and physicians use may be in short supply or may have been superseded by better versions. And these are versions that remain out of the hospital's fiscal reach because of budget constraints. And this is just a quote from the book. I asked the chief resident to explain the difference to me between Alpha and Omega. And Alpha is this public hospital which sits literally right next door to Omega, which is a private hospital. Private hospital Omega does not take Medicaid, but at Alpha, most of the patients receive Medicaid for their public health care. And this resident just explained to me that Alpha literally does not have the same equipment that Omega has. Omega can run scans, they can do better quality scans, the equipment is there. Meanwhile, if you're stuck at Alpha, you might have the same needs, health needs, as a privately insured patient at Omega, but you might not be able to get the same quality of diagnoses because the equipment just is not there. So I repeat, Implicit bias as a theory of racial disparities in health is radically incomplete. We have to pay attention to structural racism. And finally, let us not forget social determinants of health. For the uninitiated, social determinants of health are the conditions under which people live that affect their health states. Critical scholars are committed to the idea that these structural factors, right, like the availability of healthcare, quality schools and education, non-hazardous jobs, safe and secure housing, non-violent, unpolluted cities and communities, these structural factors go a long way towards explaining the poor health that people of color have. There are some studies too numerous to document, or rather too numerous to count, that document that the environments in which racial minorities live, work, play, and age are all likely to compromise their health. And it is important to underscore that there is nothing inevitable about the fact that people of color inhabit the most polluted environments. There is nothing inevitable about the fact that people of color inhabit these environments while also lacking the means, like health insurance, to protect their health. The World Health Organization's position on this issue is compelling, right? The organization writes that the unequal distribution of health-damaging experiences is not in any sense a natural phenomenon, but is the result of a toxic combination of poor social policies and programs, unfair economic arrangements, and just bad politics. So again, sure, implicit biases harbored by medical providers may be impacting the healthcare that they give patients of color, for sure, but the society in which people of color are living is doing most of the heavy lifting when it comes to shortening and reducing the quality of their lives. And so I will stop there and I will pass it on to Professor Mujahid.
Sorry, just needed to unmute myself, and that was an excellent introduction. And I will try to be, as, well, there will be some redundancies to sort of go deeper into some of the points that were just raised, but I'll try to also address some additional points. So I want to begin by thanking the organizers of this really important and timely panel. And I think, I want to also acknowledge the fact that these are very tumultuous times, that we are seeing how race, law, and public health are coming together right before our very eyes in the era of two major unnatural disasters, and that's the COVID-19 pandemic, and then the latest resurgence of the public viewing of violent killings of unarmed Black men and women by law enforcement. And so it's within this backdrop that I will share a few additional comments. And so the points that I want to really emphasize during my comments are, number one, to kind of describe the current pandemic and the broader set of disparities that exist in relation to sort of health and life chances over the life course for marginalized populations. I want to talk about the limitations of focusing on social determinants without explicitly naming and calling out how structural racism is playing out. And then I want to end with the critical role that structural racism will play in sort of shaping our path forward. So when I began giving the kind of similar panels through Berkeley Conversations a couple of months ago, it was after the data was beginning to be released. This was data on COVID-19 and how it was disproportionately impacting African-Americans. So several states started releasing data in the first week of April, showing that COVID-19 was disproportionately affecting African-Americans to an extent that was alarming for some. So they would represent, for example, in the state of Michigan, 14% of the population, but 41% of the coronavirus deaths. And so this started the kind of national alarm of what was going on, what was underlying these kinds of disparities. And I think many of us who study the health impacts of social inequality were not surprised by some of the leading explanations. These were explanations around chronic health conditions, as an example, and the data are very compelling to support this kind of hypothesis. So we know that data coming out from the Centers for Disease Control showed that over 90% of those hospitalized across all ages had at least one chronic condition, and that's even among younger individuals. So for those who are 18 to 49 years of age, 85% of them also had at least one chronic condition. And if we know that African-Americans, Latinx, and other marginalized populations have more of these chronic conditions, then that is sort of a leading explanation for why the burden of COVID-19 and so many other things are worse in these communities. But then we also heard other explanations that are consistent with this idea of blaming the victim or personal responsibility. So the fact that certain communities are more likely to be essential workers and have high-risk jobs, that they have limited ability to social distance, that they had limited information to understand the importance of social distancing or using PPE and other things like that, or limited access to the PPE. But again, these are mostly focused on individual level explanations for the COVID-19 pandemic and the unequal burden of it. And so then the conversation quickly shifted to this idea that, well, what's missing to the story is social determinants. Social determinants of health are really key in understanding this kind of inequality from COVID-19, but also other kinds of health inequalities. So things tied to housing and food security and neighborhood conditions began to become the bulk of the conversation, sort of moving beyond these limited explanations around health behaviors and chronic health conditions. And so I have sort of spent the last 15 years of my career studying some of those social determinants. So as an example, I've studied the ways in which physical environments tied to healthy food access and walkability and other health promoting resources affect cardiometabolic outcomes, as well as aspects of the social environment related to crime and social support and cohesion, how those things are all affecting the very health behaviors that we sort of talk about a lot within public health, but then also the subsequent outcomes that we see in terms of the disproportionate disease morbidity and mortality due to some of the leading causes of death. And so these studies that I've been a part of and others have been a part of have really documented how neighborhood environments are associated with a variety of outcomes, not just cardiometabolic, but from infant mortality and preterm birth outcomes, sort of and other outcomes over the entire life course. And so this has become sort of a premier area of study and also a focus for the kinds of interventions that we should be creating. The more data that comes out in relation to COVID-19 is also supporting this idea that place may matter. So there's some data to show that counties that are hardest hit have higher levels of PM 2.5, have lower levels of median household income. So again, that there are these features of places that are sort of underlying what we're seeing in relation to COVID-19. And so if we think about some of the recommendations that might come out, what are the kinds of interventions or policies that we need to focus on to tackle COVID-19 and to tackle other larger health disparities, we could focus in on neighborhood environments as an example. So we know that Blacks and other minoritized groups are more likely to live in structurally vulnerable places, that they also are more likely to have sheltered in place in these structurally vulnerable places, and that they are returning back to these structurally vulnerable places as we reopen society, that we could focus on improving features of environments to make them conducive for making the kinds of health choices that you need and minimizing the kinds of health risks that you need. And this supports this idea of really thinking about the root causes. Love to say we're thinking about root causes. We want to think about neighborhood conditions. We want to think about income inequality, and we really want to think about the root causes. But the danger in doing so is that there are these unintended consequences of the very things that we might target as a root cause approach. So as an example, I began doing some work on gentrification and thinking about how this process of renewal or rebuilding that's accompanied by the influx of affluent individuals and displacement of poor residents and often residents of color, how that is actually impacting health. And so a team of mine actually did some analyses where we looked in the state of California, and we showed that gentrification didn't have an association with health in the general population, but that within African Americans, those who lived in gentrifying areas had worse self-rated health. And then there are some other analyses in the state of New York and New York City showing that individuals that were displaced from gentrifying areas had higher emergency room visits, higher mental health related visits and hospitalizations compared to those individuals that are living in gentrified, non-gentrifying areas. And so I think on its own, then the idea would be, okay, well, let's focus in on improving neighborhoods and implementing local policies and initiatives and ordinances that will protect the most vulnerable residents so that there's rent control so that they can stay a member of those communities. Perhaps that there is a way to provide supplements. We like to think about that as well. So this idea that we can just improve places and then just make sure that there's no displacement or that we limit the displacement in order to build these effective public health related interventions and strategies. But the problem is that what we know is if we don't dig deeper, if we don't think deeper in terms of what the root causes really are, we're going to miss the mark. So as an example, there's some data that's been coming out of UC Berkeley through the Urban Displacement Project showing that in Oakland, as an example, that 83% of the areas that are currently gentrifying are areas that were redlined historically. So if we think about what that means that the areas way back when the Hulk maps were created that we know was this way to sort of bail out homeowners after the Great Depression, and these undesirable areas, the strongest predictor of those areas was the concentration of Black residents. And so those areas that were deemed as undesirable, there are lingering health consequences of those areas now. So for example, a graduate student led some analyses that I was a part of showing that in 8 California cities, residents of historically redlined areas were twice as likely as their peers to visit emergency rooms related to asthma, and that this was a function of having higher levels of diesel particulate matter in these redlined areas. And this is sort of areas 80 years ago that were redlined, and the lingering health impacts of those areas even today. And so we also know that there's a lingering impact in terms of who lives in those historically redlined areas and who can make it out of those historically redlined areas. But the wild card to all of this is the fact that now those areas are being reclaimed. And it's this reclaiming that has a historical root within slavery, colonialism. And if we are not clear about the way in which that has created a system of racism that is continuing to play out to perpetuate and exacerbate disparities, even today and moving forward, then we're going to miss the mark in terms of the laws and the policies that we're trying to create to combat health disparities, to promote health equity. And so, one of the things that I've been thinking a lot in terms of the work that I've been doing is sort of how the current sort of year that we have been through, that began with the 400-year commemoration to when the first slaves were brought over on the White Lion ship in 1619 to today, and everything that's happening with the pandemic, with police violence. This has been a year for critical reflection to think about the ways in which this legacy of slavery and colonialism is continuing to play out. And so if you think about it in terms of the conditions of Black people in the United States, one could argue, well, how long has it been since we have been free, or since we have been enslaved, since we have been in a system that promotes our livelihood and allows us to thrive? For some, that could be 61% of the time that we've been in this country. We've been sort of in these optimal conditions. That would be if you would argue that 1865 was the year in which we were granted our freedom. For others, they would argue that, well, maybe perhaps only 14% of the time have we been sort of really free, because if you think about the 1964 Civil Rights Act, maybe that's when we actually gained equal rights. But for others, they can come up with plenty of events and offenses that have happened since 1964 that will call into question whether or not we are even free today, whether we are not sort of still in a system that is creating the kinds of inequities that are preventing us from even being able to live, as we are seeing play out sort of daily on the news currently. And so if we really want to think about sort of laws and policies moving forward, we have to be clear on naming racism and how the system of racism is playing out. We have to understand how it's playing out in relation to criminal justice, education, credit markets, housing markets, healthcare systems, And there's already plenty of research showing how racism becomes embodied. We know the kind of physiologic processes that sort of happen within the body. We know how it manifests in terms of a whole range of health-related outcomes. And so we don't need research telling us that racism is killing us. Instead, we need to figure out how we can incorporate a system and understanding of racism into the kinds of public health interventions that we create. So an example of this is Khiara Jones has a really powerful cliff analogy where she talks about our approach in public health in relation to our primary, secondary, and tertiary prevention efforts. So the tertiary prevention efforts would emphasize the fact that, for example, if someone falls off the cliff, there's an ambulance waiting at the bottom to take them to the hospital. And thinking about how we would recover from COVID-19, or we would try to think about what kinds of policies and resources are needed as we're coming out of this pandemic, one would think about the fact that, well, perhaps there are not enough resources, there are not enough sort of ambulances that exist to actually deal with the problem. So then we would think about our secondary prevention strategies. Well, let's create the safety nets or rebuild those safety nets that are dismantled halfway down the cliff, right? So as people fall, perhaps it will soften the blow. But the problem is that, and where we need to focus in terms of our primary prevention efforts, is that there are too many people on the edge of the cliff. And the fact that this many people are on the edge of the cliff means that those secondary prevention programs, those safety net programs, those rebuilding kind of individual and family level resources and community clinics, that's not going to be enough to shoulder the burden of how many people are actually falling off of the cliff. And in order to move people back up off the ledge, we have to really think critically about how we create atonement for the historical insults that continue to happen currently, that are really sort of creating a situation where some people have more opportunities and access to live the kinds of sort of health promoting and make the kinds of health choices that they need to live a healthy life, and other communities are starting 12 feet under. And if we're not willing to have those kinds of conversations, which is how are we going to develop policies that dig people out of that hole? How are we going to think about the ways in which we can level the playing field? And it's not going to come from invest equally in everybody in every community. And it's hard enough for us to do that. So as much as the conversation has begun to start to think about, well, maybe we need to be investing in low-income communities or investing in marginalized communities. We don't know, we haven't seen the sort of the evidence that that's going to actually happen, and that's not going to actually be enough. So really thinking about what are we going to need to do to up the stakes to really create the kinds of interventions that consider how racism is operating, how we can stop it in its tracks, and how we can change course to sort of dismantle this system that racism has built in order to actually achieve the health equity that we want in this country. So with that, I will turn it over to our next presenter, and thank you for your time.
So thank you, Mahasin, and many thanks to Dean Chemerinsky and the Berkeley Law community for having me here today to talk about this important topic. So this past weekend, my parents celebrated their 50th wedding anniversary. They have had a fantastic half century together, and in many ways, they represent the American dream. My father immigrated to the United States in his 20s and met my mother, who grew up in a rural Jim Crow Virginia county. They have worked hard and now live a comfortable life. But the beginning of the relationship was not glamorous. They lived in a trailer and my dad worked at a local chicken processing plant. Times were hard, but they loved each other. One day, my dad was cutting grass with a push lawnmower and he ran over a brick or a rock. It shot out the side of the lawnmower and crushed his ankle. He went to a nearby hospital and a white doctor walked in and took a look at the damage to his lower leg. Almost immediately, the doctor told my dad that he would need to amputate his foot. As my father tells the story, he sat up, looked the doctor in the eye, and said, "Absolutely not. Put a cast on it. I'll be fine." He actually used more colorful language than that, but given this forum, we'll leave it at that. My father is now 82 years old, and his foot and ankle are just fine. He has never had problems with it, and I don't think he even has a scar. But in that moment, a doctor was eager to fundamentally change his and my family's life by casually recommending that they cut off his foot. I begin with this story as a way to start a conversation about race, racism, and health disparities in the United States. Black people are roughly twice as more likely to have a limb amputated than whites. There are certainly different variables that go into the decision to amputate a limb, such as disease status and access to healthcare. But the bottom line is that these types of racial differences tend to persist, even when controlling for many of these factors. My father could have been one of these statistics. Fortunately, he pushed back. My comments today will not be about amputations. Rather, I want to talk about how we use and deploy the idea of racial disparities in healthcare and public health. The term health disparity became popular in the early 1990s and is meant to do more than describe any type of difference between groups or individuals. The term health disparity has an important social justice component to it that is meant to capture the idea that a particular difference in health outcomes between groups is driven by some sort of social, economic, or political injustice. Underlying this concept is the idea that the observed difference is preventable and tied to broader historical projects of exclusion or discrimination. The disparity framework understands that not all peoples or groups can have the same health outcomes. For example, the fact that a Major League Baseball pitcher might have more arm surgeries than the average person is not a disparity. It's a function of a highly specialized and well-compensated skill set. But when social inequalities such as poverty or environmental contaminants drive the gaps in health outcomes experienced between vulnerable populations and everyone else, we can see that gap is created by an injustice that we ought to remedy. The disparities framework has become pervasive in healthcare and public health settings. It is the dominant approach for measuring and assessing these types of population differences, as well as for developing policies to reduce them. Similarly, the idea of health equity has developed as an underlying principle that drives conversations on how we should resolve disparities. Health equity is the idea that people should be provided tools and resources so that all people can achieve a baseline level of health. This might mean providing more resources to some populations to make up for certain inequalities, as opposed to letting the free market determine things. Health disparities and health equity are certainly laudable goals. It's important to understand how social, economic, and political factors drive many of the gross disparities in health outcomes that otherwise would not exist. And health equity provides a normative goal for how to think about reconstructing healthcare and health policy so that these inequalities can be reduced. But these frameworks also have shortcomings that need to be discussed. Public health practitioners certainly have good intentions in measuring the social determinants of health and how they might impact differential outcomes between groups. But too often, this exercise devolves into a routine of simply identifying, quantifying, and measuring differences that, quite frankly, any member of a vulnerable population can tell you already exists. It's not clear to me that building large data sets and running multiple regressions on powerful computers is necessary to tell us that part of the reason Richmond has worse health outcomes than Marin is because Richmond residents have less access to healthy foods and live next to a large petroleum processing plant. Yet, here we are, paper after paper, big data sample after big data sample, regression after regression. We are told that Black folks have less opportunity to good health than whites. We know this. And in the process, conversations about health equity, or what we ought to do about this, are often sidelined. I'm also frustrated by the policy implications of the health disparities and health equity frameworks. These positions largely imply that resolving disparate health outcomes between, for example, Black and white populations is largely an issue about redistributing resources. Don't get me wrong, we need a serious and far-ranging conversation about equitable access to resources, from food to housing to jobs. But what this emphasis doesn't take as seriously as it should is the extent to which race and racism are not simply one of several equally situated determinants of health, but that anti-Blackness as a specific ideology is central to how medicine, healthcare, and public health are organized. Over the past few weeks, we have witnessed a massive transformation in how we think about dealing with a significant health disparity plaguing the Black community: police use of force. Studies show that Black men are up to 3.5 times more likely than whites to be killed by the police. 1 in every 1,000 Black men will die at the hands of law enforcement. As I noted in a recent essay in the Washington Post, police violence is a pandemic in the Black community. The protests that we see in the streets on a global scale are demanding that policymakers stop thinking about the police use of force problem as something caused by resource deficits, such as lack of training or too few officers on duty, which might lead some people to be overworked. Instead, the movement that we are currently in is stridently demanding that we put the resource question aside and focus on the main problem, anti-Blackness in law enforcement. What these protesters are demanding is an acknowledgement that too many aspects of law enforcement and criminal justice have historical ties to anti-Black institutions such as slavery, the Black codes, and Jim Crow that manifest themselves in contemporary policies that fail to acknowledge the humanity of Black people. Their argument is clear. To stop police from killing Black people, we first have to acknowledge and address anti-Blackness as a systemic problem. Acknowledging anti-Blackness is not separate from the issue of rethinking resource distribution. Indeed, much of the police protests are about shifting resources from the police to community groups to help address problems like housing and mental health care. However, anti-Blackness provides a sharper and more accurate lens from which to develop policies that can help reduce police killings. This moment with regards to protesting against police violence can be quite instructive for how we think about our approach to other racial disparities in health. Medical professionals are not unlike members of other social institutions. That is, they often simply don't like Black people. This is a harsh reality, and I do not mean to overgeneralize, but the health disparities conversation has largely engaged in vague conversations about abstract notions of race and have not fully centered the specific impact of anti-Blackness and how it has been embedded in almost every social, political, and economic institution. Moreover, this conversation has to seriously grapple with how anti-Blackness manifests itself in almost every part of healthcare interactions that Black people have. And no simplistic shifting of resources from A to B can address this fundamental problem of anti-Blackness in healthcare. Indeed, the idea that Black folks only need resources to become healthier obscures the profound depths of anti-Blackness and places the burden on Black folks to, in a sense, help themselves. Let me be clear, I'm not talking about implicit bias. To be sure, implicit bias can be an important determinant in some clinical outcomes to the extent that providers might react differently to some people due to race. When I say anti-Blackness, I mean that entire systems and institutions in and around medicine are organized to minimize the humanity of Black folks, regardless of resources that might be provided. This is what Khiara gets at in a stunning ethnography in her book, Reproducing Race, that examines how poor Black mothers with access to public healthcare systems are mistreated and have bad outcomes despite this availability of medical care. This also mirrors what Tina Sachs talks about in her book, Invisible Visits, which chronicles the healthcare challenges of middle-class Black women and their difficulties achieving some notion of health equity with their peers. What these books reveal is that the question of health disparities is not just about resources. It's about anti-Blackness in medicine. And this is a problem that is endemic throughout every aspect of healthcare and health-related research. Black people's lives are not taken seriously. A reorientation towards combating anti-Blackness has significant implications for health policy. Policymakers have to understand that anti-Blackness is violence. When Serena Williams, a millionaire sports superstar, almost dies giving birth because nurses and doctors would not listen to her, it is clear that resources are not the only problem. And simply redistributing resources is unlikely to resolve a maternal death rate among Black women that is 2 times higher than white women. We have to radically rethink health policy in a way that aggressively recenters and focuses on anti-Black sentiments that are at the heart of these health care endeavors. This has to begin with social movements to change medicine and public health. Just as these movements are shifting policy in law enforcement, so too can they have an impact on health policy by centering anti-Blackness as an institutional problem that must be rooted out and destroyed. Black lives have to be made to matter now more than ever. And I'll now pass it on to our last speaker, Tina Sachs from the School of Social Welfare.
Okay, thank you so much. That was an incredible set of takes on an incredibly important issue to all of us, and it is a hard act to follow to go last, but I will do my best. And to begin, I just want to just to say that what I'm going to try to do here is to provide a few comments about the pandemic, about COVID-19, and about social policy, and about the uprisings that we have seen, the protests against police violence, and which is essentially state-sponsored, state-sanctioned violence against Black people and other people of color. And I want to try to stitch them together and flesh out what I see are some of the relationships between what we have seen occur with COVID-19 and the uprisings against police violence, and then to move us into a discussion about what it might mean to defund institutions. We've heard this call to defund the police frequently in the conversations about the uprisings here in the United States and around the world. But what would that look like if we actually shifted some of these resources to institutions that might actually improve the health of Black people, improve Black lives, as opposed to institutions that we know actually have a negative effect on Black people's health and well-being? And so to begin there, I actually wanted to start with a quote from Anduranti Roy's article, in which she talks about the pandemic as a portal. She talks about, so I'll read just a brief quote from her essay, in which she says, "Whatever it is, coronavirus has made the mighty kneel and brought the world to a halt like nothing else could. Our minds are still racing back and forth, longing for a return to normality, trying to stitch our future to our past and refusing to acknowledge the rupture. But the rupture exists. And in the midst of this terrible despair, it offers us a chance to rethink the doomsday machine we have built for ourselves. Nothing could be worse than a return to normality." She goes on to say, "Historically, pandemics have forced humans to break with the past and imagine their world anew. This one is no different. It is a portal, a gateway between one world and the next. We can choose to walk through it, dragging the carcasses of our prejudice and hatred, our avarice, our databanks and dead ideas, our dead rivers and smoky skies behind us. Or we can walk through it lightly with little luggage, ready to imagine another world and ready to fight for it." And so as I think about her charge to us, I think about, of course, the recent worldwide uprisings against state violence that we have seen in the form of policing. And I think about the fact that we have been here before. We have seen the movement for Black Lives and other activists who really laid the groundwork for this. This emerged just several years ago. And only now, really in conjunction, I think, with COVID, have we seen the uptake of these ideas around so many people being out in the street and thinking about police violence as a public health pandemic, really engaging with, hopefully deeply, the scourge of anti-Blackness that our country was essentially founded on, and of course on white settler colonialism. And I tend toward pessimism, but I am slightly optimistic that this can be a portal for us. And so what I hope we can do in all of our conversations is to try to think about what would this door look like if we walk through? What will be on the other side if we were actually to dismantle the forms of discrimination, anti-Blackness, the erasure of Indigenous people, if we actually address some of that in our social policy? And so I am a person who thinks about the connections between health and social policy and social work. And it is not surprising to anyone that we see the same people being disproportionately affected by COVID and by state violence. And I think the portal that Anduranti Roy speaks of is really an opportunity to rethink or to come up with a rational social policy for the United States as one of the largest, as the biggest economy in the world, without universal health insurance, without paid sick leave, without childcare subsidies. This really leaves us in a situation in which it is not surprising that we have the most deaths from COVID in the world. We know that Black people, Native people, Latinx people are disproportionately affected by COVID. And as Mahasin and others have already mentioned, Black people are often working in public-facing jobs in which they could not work from home. They could not shelter in place safely. working in industries in which they do not have paid sick leave, perhaps living in neighborhoods that expose them to more airborne particulates, as Mahasin also mentioned, that led to asthma or to other underlying conditions that they were often blamed for, as though these individual level, their individual level health conditions were their own problem as a result, as opposed to being the result of structural discrimination that has gone on essentially since this country began. We also know, of course, too, that health insurance, not having health insurance is a huge issue for many Black people and many people of color. And certainly as in Khiara's work and in my work, as we have fleshed out the ways in which even if you do have insurance or once you do arrive at the healthcare encounter, many Black people are not taken seriously once they get there. And I heard many anecdotal accounts of people who presented to emergency rooms with COVID symptoms only to be turned away. Some of those people actually died. And those were people who they're sort of the recognition of their humanity once they went to the doctor simply was not there, as Osagie has already referenced for us. Some of these problems can be addressed through social policy, like paid sick leave or universal health coverage, but certainly the root of this, the core of this in many respects, is an anti-Blackness that goes so deep that we have not been able to really address it in our country. And so what I'm arguing here really is that we need both universal programs, social policy programs, to really rationalize the American healthcare system, the American social policy system, the American safety net system. We need these universal kinds of programs. We certainly need targeted programs to deal with the legacy of structural harm that Black people, Indigenous people, and other people of color have experienced intergenerationally for far too long in the United States. And so as I think about the United States, again, as the largest economy in the world, as supposedly the country that is the most advanced, although I think the COVID epidemic lays bare many of the enormous holes that we have in terms of our public health infrastructure, in terms of testing, in terms of hospital infrastructure, et cetera. But it does call to question, I think, a comparative approach to try to think about what other countries do in terms of their social policy. So we do know that in countries, that other countries spend much more on social services like income transfers, housing subsidies, childcare subsidies. They have lower healthcare expenditures, and which is really not surprising in some respects for people who are interested in social determinants of health. Countries that spend more on income transfers, housing, childcare subsidies have better health outcomes. They do better in terms of infant mortality, life expectancy, et cetera. And so this is what I hope, that if there is a portal, if there is an opportunity here for us to think about what we might do differently, I hope that we start to think about a rational social policy in the United States. For example, a few years ago, Bradley and colleagues found that compared to other countries in the Organization for Economic Cooperation and Development, the United States actually spends more on health service expenditures and does much worse in terms of health outcomes than other countries. And this is something I think we really need to take a good look at here. I also think that we cannot think about expenditures in terms of social services without thinking about the profound anti-Blackness that this country is really founded upon. Because one of the reasons we know that in the development of social policy in the United States, anti-Blackness is rife with anti-Blackness. So that the Social Security Act, much of what forms the foundation of social policy in the United States, was explicitly developed to exclude Black people from those programs. And as a result, I think many people would argue we do have a relatively stringent social safety net in the United States compared to other developed nations. And this cannot be understood separately from anti-Blackness. We know that, of course, obviously, when it comes to public health, that the social determinants of health, where we live, where we go to school and work, have a huge impact on our overall well-being. And that is much beyond what happens when we step foot inside a doctor's office. And so, although here in the US, we typically think about why we have we spend almost 20% of GDP on healthcare services and don't do very well, we don't get very much for our money, even though we're spending that much. But we don't tend to think about what actually determines people's health, right? It's where they live, where they work, whether they can breathe clean air. And those are the kinds of things that are social goods that we really need to address. And I'm cautiously hopeful, I guess I would say, that perhaps the portal is an opportunity, that the pandemic and the uprisings, the long work that activists have done to get on the ground and agitate, that might be able to push us forward to develop a system of rational social policy that can address some of the causes of the COVID epidemic, or I'm sorry, that exacerbated the COVID epidemic. And so that being said, I just wanted to make a shift back to some of the things that have been on my mind lately, and likely on the minds of many of us as we've watched deaths and illness from COVID tick up disproportionately, affecting Black, Latinx, and Indigenous people, as we've watched the uprisings against police violence around the country and indeed around the world. We've heard the term defund the police come into day-to-day use, at least among some people. And I think while defunding the police is a very charged term and it means many different things to many people, I think in some respects it's a shorthand. It's a call to say, to step through the portal of Underati Roy's imagination and to think about a world in which we funded the institutions that would actually have a positive effect on our health and well-being, in which we redirected funding from an institution that was never designed. The institution of policing was never designed to respond to mental health crises, domestic disputes, to help manage a child who might have had a developmental issue. It was never meant to do that. And so if we redirected funding from an institution that was never designed to deal with social issues, and perhaps redirected that funding to institutions like schools, childcare, housing, that could actually improve our health, I think this is the kind of thinking that we need to embrace to move forward. And that said, this clearly cannot be done without actually dismantling structural racism, anti-Blackness in particular, the fulcrum upon which I believe the rest of structural racism rests, transphobia, ableism, and all of the other forms of pernicious discrimination that our country was essentially founded upon. And so these are certainly, to my mind, these are fundamentally social policy questions that center on the idea of repair. How might we repair ourselves? And certainly the idea of repair leads me to think about reparation and reparations. And so as we think about a universal approach through these other social programs that are commonplace in the rest of the world, universal healthcare, childcare subsidies, housing, that we think about universal programs, but we also think about how do we address the profound harms that we are still living with? How do we address for Black people these harms? And can we think about critically what reparations might look like? I think how we take up this charge is going to be critical to where we end up as a nation. I think we know what to do, as other people on this panel have already mentioned. We don't need more data to describe and document health inequities and health disparities. I think we also know that many of the biases that we see in the healthcare system are not implicit, but actually quite explicit. I think we know all of this. I think this is really what we have on our hands here is really a matter of political will, and perhaps most importantly, political power. Because we know that power concedes nothing without a fight. And so although we know probably what needs to be done to redress the harms that have been committed here against Black people and many other people in this country, I think we have to try to think about who wins and who loses here if we do redistribute some of these forms of political power. And so with that, I will close and thank you for the opportunity to speak to you today.
My thanks to all four of you for wonderful, thought-provoking presentations. It's certainly everything we have hoped for in creating this series. And we have a number of questions and a few minutes to be able to focus on those questions. Let me read the first of the questions to you. It says, could the panelists speak to the impact of COVID-19 and access to healthcare for the Native American population? As of June 9th, there were 6,100 reported cases of COVID-19 in the Navajo Nation and Hopi Reservation land since the middle of March, with the death toll reaching 285. That's per capita case rate over 2,500 per 100,000 people, one of the highest in the United States. What's making the virus even more severe is that Native Americans aren't receiving the same level of assistance as other states in the country. Federal aid is almost non-existent. Do any of the panelists want to talk about race as it relates to the Native American population, and particularly with regard to the COVID-19 epidemic?
Well, I can start off with a few
Thank you.
comments. I think that, you know, the panel, we have focused a lot of our comments on the experience in relation to COVID and a broader set of health disparities for Black populations. That doesn't mean to discredit the fact that there are very significant disparities for other populations, including Native populations. And I think one of the challenges that we see is that the story is often not necessarily not represented in the literature, but underdeveloped because of the limited data that exists. But there are definitely efforts currently to try to think about the ways in which we need to invest more in areas in which Native populations exist. For example, there's a lot of emphasis on rural health, and although one focus for the rural health and the sort of health of rural Americans is rooted in the experiences of poor whites in the rural South, there's also a strong emphasis on the fact that rural areas represent the majority of Native populations in the United States. And so better understanding how the kind of limited access and resources that exist in these populations, as well as with many others, kind of how structural racism is playing out for Native populations is a critical next step to eliminating disparities for Native populations. I think the root that we are seeing for the common thread, I would say, that we're seeing in terms of the Black experience, the Native experience, again, is based on these deep-rooted historical insults and our inability to name them for what they are and reconcile them in a way that's meaningful in terms of our actions, our policies, and our resources.
Does anyone else want to speak to that question? If not, I'll ask you another question that came in. What is the relationship of issues of race in law to health insurance? The Affordable Care Act increased health insurance for 40 to 50 million people. Striking it down will mean no health insurance for at least 22 million. Last week, the Trump administration urged the Supreme Court to declare the Affordable Care Act unconstitutional. Can the problem of race and health be dealt with without solving the insurance crisis? I know, Professor Sachs, you spoke to this some. I don't know if you want to elaborate or if others want to talk about the relationship of health insurance to race and health policy.
Sure, I can say a little bit about that. I mean, I think like most of social policy in the United States, you really cannot think about, you can't separate race and more importantly, racism from social policy. So for example, many of the states that chose not to expand Medicaid through the Affordable Care Act were states in the South with predominantly or a large percentage of the population were Black. And so that clearly is a signal to Black people to say, listen, we don't want you on the road. We don't want you to receive Medicaid. We are not going to expand health insurance to you through this system that clearly works. And so using social policy as a tool essentially to keep some people to block access to health insurance is not new. I think it is absolutely not an accident that the Trump administration has gone after everything that the Obama administration has tried to put in place. And I think that a lot of that has to do with their animus toward Obama as a Black person. And so it is certainly, and sort of from the healthcare access side, it is very difficult to try to think about how we could expand health equity or how we could do away with health disparities without also addressing universal health coverage or expanding health coverage, health insurance coverage to everyone who needs it. So these two things are very closely linked.
Do others want to speak on the health insurance issue?
I will just add that, and I just want to reiterate a point that my co-panelists have already made, but it is impossible to understand and explain the incompetence of the US's social safety net, the fact that we don't have paid maternal or paid parental leave, the fact that we don't have universal health care, the fact that we don't have adequate food supports, adequate housing. We cannot understand the incompetence of the social safety net without taking seriously racism. Racism explains why the countries that we like to call our peers in Western Europe are doing so much better when it comes to taking care of vulnerable populations. And so when it comes to health insurance, the reality that we do not have an adequate system of healthcare in the United States can be explained in terms of racism, and specifically in terms of anti-Black racism, when Black people have been figured as those who will benefit from this system. If Black folks are the ones who will benefit from a system that cares for the most vulnerable, then we have done wonders as a country to make sure that system does not develop. But I do want to reiterate, so I do think that the ACA does wonder, or it works well to expand access to what some would describe as a basic human right, as something that most would understand that an industrialized nation ought to provide for its citizens. The ACA does a good job towards expanding access to that good, but we also ought to keep in mind that the ACA simply expands our two-tiered healthcare system. It's a bizarre system. It's a bizarre system to have one's ability to access health insurance linked to one's employment, such that when one loses one's job, one loses one's healthcare. So it's a second best. The point of my remarks is to say this is a second best system. If we really took equality seriously, if we really wanted to remove the ability of anti-Black racism to manifest, then we would be really working towards a single payer system and not towards reinforcing our two-tiered healthcare system.
Osagie, Mahasin, either of you wish to speak to this question?
Sure, I'll take a stab. I think just to follow up on comments folks have made earlier, it's important to acknowledge that a big part of the health disparities literature is really documenting the fact that access is a necessary but not sufficient variable in resolving health disparities. That is, the question of access to insurance is certainly needed and certainly helpful and beneficial. But the bigger problem of resolving these massive disparities in health outcomes, particularly between Blacks and whites, is going to require, much more difficult, entrenched conversations about redistributing wealth and opportunities. We are well aware of the long fight that has happened in this country towards making sure that folks have access to health insurance. It's going to be an even more difficult conversation to start addressing these entrenched social determinants of health that drive many of these disparate outcomes. So again, we should continue to make sure that access is on the table in terms of our health policy conversations, but we also have to make sure that's a starting point for a much broader conversation.
Mahasin, anything on this or I'll give you the last word.
No, just to say that we also have to recognize that in addition to the inequality that people are entering into the healthcare system with, that prevents the healthcare our access to healthcare to be the end all be all. We also have to remember that when they enter into that system, the same kind of structural inequality and decisions and policies that affect everyday life in terms of how people are discriminated against on a daily basis in society also exists within the healthcare system. So going back to Khiara's points about implicit bias and how it's playing out within healthcare, that once you enter the healthcare system, that it also is not enough to ensure that you get the adequate healthcare that you need from a kind of tertiary or secondary prevention perspective. So just remembering that there are also real limitations to the healthcare system once we provide universal access in a single payer system.
Thank you. We're out of time now. I apologize. We did not get to all the questions that were received. I know I speak for a very large audience in thanking all four of the speakers for their terrific presentations. I appreciate you taking the time from your busy schedules to do this, and we're all much better informed and educated thanks to your insightful remarks. The next panel in this series will be 2 weeks from today. On July 13th, there'll be a program on race, voting, and elections. I hope you'll join us then. Thanks so much. Take care and be safe.